Yeah, that's a very interesting question and great trial that was presented and led by colleague and friend Neeraj Agarwal. Um, big effort to show overall survival in an unselected population. We already showed that with RPFS, but I think this still has a lot of people still wondering what's going on here. Is there truly synergy with the PARP inhibitors and the ARSIs? I know there's definitely preclinical work that has shown that in the past too. And also, Dr. Hussein's Brackway study also showed that if you give it together, opposed to sequentially, you actually have a longer magnitude of benefit. So I think there's probably definitely some kind of synergy going on with the coupling of the agents. But I think the magnitude of benefit is pretty obvious that if you have a BRCA2 mutation or HRR alteration, you're going to have a much bigger magnitude of benefit. The other thing is that the population that TALAPRO-2 studied is sort of dwindling, right? Because all these patients nowadays have prior ARSI exposure, at least in the academic settings. But in the urologic practice, I think we are seeing people that are only on ADT and progressing to CRPC. And also, only 20% of patients had chemotherapy in TALAPRO-2. So I would put a lot of these factors into my decision making for a frontline CRPC setting, especially when there's other treatments available, like chemotherapy, like lutetium PSMA, and other clinical trials. I mean, we've known from preclinical work that it's kind of vice versa. ARSIs alters PARP gene regulation and the vice versa, right? PARPs also alter the androgen receptor gene expression as well. So it kind of makes sense that there is some kind of synergy. I don't think that the field completely understands it, but I think now that we've had several trials that have investigated this, well, we think that at least some of us do think that there is, biologic rationale for this. I think from the get-go in metastatic prostate cancer, genomic testing is really key. I think that's something that the field should really do at a standard of care. I do it in the frontline setting, but also it's also important to do it in the CRPC setting because there is evolution of genomic changes as disease progresses, right? And also with liquid testing, right? Prostate cancer is difficult to get biopsies when the patients recur because a lot of times it's bone only, and patients might not want invasive testing at that time. But liquid testing is getting better, getting more sensitive as far as sequencing. So I think doing the liquid biopsies as the tumor progresses will help pick up more HR alterations and include more and more patients that are eligible for this. Yeah, I mean, just taking into factor the patient that you're looking at in front of you. Has this patient already seen ARSI? Is this a patient that really reflects TALPRO-2? Has this patient seen chemotherapy before, right? Because chemotherapy is still very effective in the CRPC setting. And then we also have lutetium PSMA as well. This is technically approved for the taxane exposed patient, but PSMA-4 has shown that you can have a similar type of benefit in the pre-chemo setting as well. So taking into consideration all of these, including what does the patient want? Does the patient want, many patients don't want chemotherapy. A lot of people are asking for Pluvicto. But I think just looking at the toxicity profile of different options in this setting, I think it's important to consider if you have a targeted therapy, a genomically targeted therapy, try to use that first because they can use they can cause anemia, thrombocytopenia, neutropenia, and you might not be eligible for for these trials or these types of drugs in chemo exposed, Pluvicto exposed patients, right? So I think considering a lot of these different factors will help us decide what to choose in sequencing therapies. As far as the TALAPRO-2 trial, there were about 60% of patients that did require any types of dose interruptions or reductions. So setting expectations with patients that this is going to happen, it's going to happen at some point. We just have to start at the standard dose. And then when we start seeing different grades of anemia or cytopenias, we reflexively act upon that, right? And eventually, patients may need dose reductions. Patients may need blood transfusions. We're getting more and more used to doing this in GU oncology. A good example of this is HIF-2 alpha inhibitors, right? We're giving patients ESAs to boost up their bone marrow production of EPO for that kind of drug. So that can also be used in this setting for PARP inhibitors if anemia is an issue. I think the fact that we had overall survival in unselected population is really interesting, and it really gets me thinking. I'm wondering if some of these patients that are benefiting are truly HRR positive, but we're just not picking it up. It's with the tissue biopsies, it could be heterogeneous, right? And then with liquid biopsies, we may not be sequencing deep enough, or maybe we're not testing at the right time. So as liquid biopsies are getting more and more sensitive and picking up even like the smallest tumor fractions that can be HRR positive or BRCA2 positive, I think this is going to be how we better select these patients and get them on these combinations to improve outcomes.